Perfect. Okay, so this morning we heard a lot about vaccine policy and some fantastic comparative analyses of approaches to managing the pandemic in different contexts. And one of the things that we know in public health, and we've learned in public health, is that generally we don't have a one-size-fits-all approach, and understanding the context to implement the right strategy is really important. And what I'm hoping to do in the next 20, 25 minutes or so is to share a little bit about the experience that we had early on in the pandemic in Israel. And hopefully there will be some interesting and relevant takeaway for preparing for future health emergencies in different contexts. So for those who don't know much about the country, I just want to share a few things because they're relevant to the approach. Just to give you a sense of scale, Israel is about the size of New Jersey, and it has a population of 10 million, which makes it one of the more densely populated countries in the world, certainly compared to European countries and to the US. It has a very young population. It's a high-income country, and generally a history of successful immunization programs with achieving high coverage for routine immunization. And despite these facts, as of earlier this year, our cumulative incidence was about 500,000 per million, meaning that according to reported data, about 50% of the population had been infected. And of course, with very little testing going on in the last year and a half or so, probably much higher than that in reality. So just to set the scene a little bit. Israel is a very diverse place, and I'm going to talk about equity in different populations. It's obviously home to, or it's an important or a central place for three of the main world religion, Judaism, Christianity, and Islam. And in addition to highly religious populations and very traditional communities, it also has a very secular population, so huge variety in terms of its populations, and huge varieties in terms of its settings. We have very densely populated urban centers in the center of the country. We have very rural and relatively wealthy agricultural, rural communities. And we also have very deprived, even semi-nomadic communities like the Bedouin communities, for example, in the south of the country. So designing a pandemic approach requires to take all these different communities and these different settings into consideration. And as I said, here compared to a few European countries in the US, generally speaking, our vaccine program is relatively successful, and we managed to achieve, at least at the national level, high coverage for routine childhood immunizations. In terms of how the pandemic unfolded in Israel, I just want to give you a very, very quick overview. It's not that different from other countries. Our first reported case was in February 2020. And our vaccine program was one of the first to be unrolled in December 2020. So we had a first wave in early 2020, and I'll go through a little bit more of the history. Fairly strict lockdown, and then a resurgence, then the beginning of the Delta wave, the beginning of the boosting campaign, which again in June, July 2021 was one of the earliest ones, and then the Omicron wave started. And as we had a few discussions, there's not much you could do to stop that wave, unfortunately. And then the subsequent subtypes of Omicron, and then essentially testing stopped after that. We went from a policy of really regular testing for almost anything. If you wanted to go to a restaurant, if you wanted to go to a bar, if you wanted to travel, you had to be tested. So we had very good data. And then the home kits came onto the market, and then there was really no real grasp of the epidemiological situation after mid to late 2022. So the best way to reduce your incidence of a disease is to stop testing, as you can see. And really, Israel was not an outlier. If we look at the overall picture of the epidemiology of SARS-CoV-2 in Israel, it was very similar, give or take a bit of the timing, to the epidemiological situation in most countries in Europe. In the beginning, though, it was quite different. We started with a pretty low mortality, pretty low incidence. And for that reason, I want to focus on the early stages of the pandemic, because I think that's where most of the lessons are. But let me go through a little bit more detail about how the pandemic unfolded. So, as I said, the first case, I think, was on the first case reported was on the 17th of February, if I'm not mistaken. And as early as March 2020, there was a national state of emergency declared, and the country put in place some of among the world's most restrictive policies, including an almost complete total ban on flying in or out of the country, lockdowns with relatively severe restrictions. You were not allowed to go more than 100 meters from your house, even to walk your dog or buy milk. Masking outdoors, not only international closures, but closures and restrictions between cities and even between neighborhoods, with roadblocks put in place. It was not possible to go from one neighborhood to another with a car. And as a result of this, our first wave was relatively small in terms of incidence, and relatively short. And Israel was touted as a gold standard in terms of how to manage the pandemic. And then 2 months later, so all these measures were relaxed, and we saw a very rapid increase in incidence. And we quickly went from one of the lowest incidents in the world to one of the highest incidences in the world. That put pressure on healthcare systems, not to the level that was seen in some European countries like Italy, for example, but still tremendous pressure on the healthcare systems. And just to give a bit of a sense of what happened after the release of, after the end of the first lockdown, I think the day after the lockdown was lifted, there was a huge beachfront concert with 5,000 people getting together. There were also religious authorities, and religious authorities in Israel carry a very heavy weight because they influence large parts of their own populations, whatever population they cater to, with some religious authorities saying that people shouldn't test, because if they tested, there was a risk that they could test positive, and that would stop them from their learning Torah activities. Equally, in the Arab population, similarly, there were a return to very large gatherings. And at that time, although this was before the war, this was already a time of political turmoil in Israel. I mean, Israel is always in political turmoil, it seems. But this was at a time where there was a lot of protests, anti-government protests, and people felt that protesting the government was more important than disease transmission. And all these contributed to this second wave that was very rapid and very intense. As a result, new measures were put in place. There was what they call the traffic light system, which was a city-by-city real-time analysis of key indicators, including vaccine coverage, including positivity proportions of testing, and mortality, to decide at the very, very local level what the restrictions would be. Schools were closed and moved online. Increasingly restrictions on gatherings, and because these measures did not sufficiently impact on incidence per capita, a second lockdown was put in place. And this was just before a set of large, September is generally the season of relatively large religious gatherings because there are major religious festivals at that time. They put a lockdown just before, so to kind of prevent increased contact and increased transmission. And we had a second lockdown between September and November 2020. And again, as the second lockdown was ended, incidence increased again, and we kind of entered these cycles of strict lockdowns, reduced incidence, opening, increased incidence, in the background of the emergence of new variants at that time. And all this is still pre-vaccine, by the way. The emergence of the Alpha variant, which led to reinforcement of criteria for exit and entry to the country, and a third lockdown. And this is the time where vaccination came into place, and I'm mainly going to talk about vaccination. Very briefly, a fourth wave in the summer of 2021, the rise of the Delta variant, and this is at a point where the population was largely vaccinated already, but because Israel vaccinated almost earlier than anyone in the world, and at the time we didn't know about the rapid waning and the very rapidly decreasing efficacy against infection and transmission, we then had further transmission, and that's the time where the country introduced boosting. And again, the first country to introduce boosting at a time of discussions about vaccine equity, and should the doses be more fairly distributed? Is it ethical to offer third doses when some country had barely started vaccinating? But it happened nonetheless. And in late 2021, our fifth wave, Omicron wave, and at that point we had another lockdown with almost total closure, a big push for boosting, and an introduction of further doses, fourth doses, and even fifth doses for a vulnerable population. And then that's where the high-quality data stops. So I want to talk about vaccination and vaccine equity, because if we look at if we look at the timeline, and here on that graph, Israel is the blue line on the left, we can see that Israel managed to vaccinate earlier than any country and achieve high vaccine coverage very quickly. I mean, here it goes to 60% within 2 months, more or less. But you have to remember, this is 60% of the total population, and at that point, the eligibility criteria was only above the age of 18, and about 30% of the country is below the age of 18. So really, it was about 85% of the eligible population. And in the end, you can see that our vaccine coverage was no higher than anyone else, but we did vaccinate earlier and rapidly and successfully. And likewise with boosting, when the booster was introduced, there was a lot of discussion about whether it should happen or not, and Israel decided to offer third doses, and that was a move that was widely criticized by WHO and member states because of the issues of vaccine equity, but the doses were available, the evidence was there, and Israel was one of the, as Professor Henry showed, one of the major contributors to data. So we knew very early that the waning was taking place approximately 6 months after the second dose, and the decision was taken, and interestingly, pretty much every country that could afford to and had doses available did exactly the same a few months later. So I want to very quickly discuss how did Israel manage to vaccinate almost its entire population within a couple of months. And there's a few, I think there's a few pearls of wisdom there, and some are generalizable and relevant to other countries, and some are very context-specific. The first one is the availability of the vaccine, and it's a pretty famous or infamous piece of information, but very early on, before vaccines were available, there had been a deal between Pfizer and the government of Israel, an advance commitment to provide vaccine for the entire population. Now, this was it was a two-way, it was a win-win situation for the country, and I don't want to talk about the global ethics of that, but between the company and the country, the understanding was that Pfizer would provide vaccines to Israel on the condition that the country would exclusively use that vaccine. And that meant that in terms of real-world evidence, the company had pure data. There was no question about what vaccine had been used. So suddenly, they had almost like a real-world trial on 10 million people, rather than the size that the tens of thousands through clinical trials. And of course, the data would be shared, and Pfizer would have access to that data. As I said, it's a small country, and it's a very concentrated population. The vast majority of the country the population lives within a very small, geographical area. So it means in terms of logistics and the ability to deliver vaccines compared to, countries like the United States or low-income countries with very remote populations and a relatively limited logistics, it's quite easy to make sure that, once you take the dose out of your -80 fridge, the furthest away you have to go is maybe 1 or 2 hours by car, so that makes things much easier. Very interesting and innovative use of communication campaigns, and I'm going to show you that in a second. A very aggressive approach to anti-vaccination messaging, meaning people that try to spread anti-vaccine messaging were identified and or either the internet access blocked or in some cases jailed when they took action that was illegal, and I'll share a few examples of that. Israel, for better or for worse, is a country that is used to managing emergencies, generally conflict-type emergencies. So that means there's a system in place, and there is a strategy in place to very rapidly mobilize the healthcare system, even the army, the police, to actually deliver emergency measures. A very centralized healthcare system in terms of data, in terms of delivery, very high data quality. And this became very important because Israel is one of the few countries which has longitudinal records going back about 30 years and linkage between its primary care data and its secondary care data. So it meant in terms of, if someone was hospitalized, for example, you could know whether he had comorbidities, whether he'd been tested, PCR tested, how many times, when, and when you're trying to do effectiveness studies, when you're trying to identify risk groups, that's incredibly valuable. And there are also cultural specificities. I don't know how many of you are familiar with Israel, but one of the key things is people don't like to be left behind. They don't like to be the last in the queue. So there's a very interesting phenomenon when vaccines came available in clinics. There was the demand far outstripped the supply. There were not enough slots. And very quickly, there'd been WhatsApp group that put themselves in place that figured out where there were leftovers after the clinic days. And people would literally congregate in the parking lots of the clinics and would wait for the doctors and the nurses as they came out to try and get vaccinated there and then. And that was actually a pretty big contribution to the vaccine coverage early on. The vaccine became a prized commodity, and being vaccinated was seen as a good thing. And if you managed to find a way to get the vaccine before the others, that was kind of almost like socially desirable. Interesting, very unique Israeli feature of not being a friar. And of course, with the data that was generated by this rapid vaccination campaign using a single vaccine, the country was able to produce, I'm not going to say most, but a very high proportion of some of the key early papers on effectiveness, on waning, on immunogenicity, on risk groups. It's a country of 10 million people, and I think they produced almost as many papers as the US, in terms of papers that really shaped policy early on. So this was an important part of the equation when that deal was struck with Pfizer. A few examples of communication, tailored communication campaigns that took place and were important. First of all, both political and religious figures. On the top left, you have the prime minister. In the bottom middle, you have the chief rabbi of Israel that got vaccinated very early on and very publicly. And these are people that, again, for better or for worse, inspire other people. Very tailored campaign. In the bottom left, you see a gamification of vaccination, and this was a campaign organized at the city level, specifically targeting young people with an event put on with music, with free pizza, and people turned up because they turned vaccination into a fun thing. On the bottom right, free food. Free food always works, it seems. And the interesting thing here was, not only was there free food, but the cities provided the food that they knew people in the particular communities they were catering for would like. So if you went to an ultra-Orthodox city, or if you went to an Arab city, the food was different. And that was important. And I remember, unfortunately, I don't have a picture. I looked for a picture, but I couldn't find it. On Christmas Day of 2020, so in the very, very early days of vaccination in Israel, I was walking in a city called Haifa, for those of you who know Israel, which is a very multicultural city. It's a mixed Jewish-Arab city, and I was walking in a Christian-Arab neighborhood, and there was a huge poster of a Christmas-themed vaccination campaign written in Arabic, and then you would walk 2 streets and walk into a Jewish neighborhood, and then the language was different and the theme was different, but the objective was the same, to encourage people to get vaccinated. So very hyper-localized tailoring of vaccination campaigns. If we look at vaccination by age and by dose, we see that overall the vaccination campaign was highly successful, especially with the elderly. And it's very interesting to see the contrast with Southeast Asia, because it seemed to be the opposite, especially for further doses, for booster doses, 3rd and 4th doses. I think I would say the 60+ knew and understood that they were most at risk, and the uptake. So if you look at 3-dose coverage for these groups, it's over 80%, and for the 80+, it's over 90%. It's a little bit lower for younger age groups, and particularly for children, the campaign never really worked, with only about 1/3 of under 18s getting vaccinated. And I think the main barrier was that by the time the vaccine became available to that age group, it was clear that the risk to younger people in terms of severe outcomes and death was relatively limited. And it's really interesting to look at the reasons for vaccination in different age groups. And this is a study that I did with some colleagues. Interestingly, when you ask people who did choose to vaccinate their children why they vaccinated, protecting their health came quite low as a reason. The main reason was because they wanted to be able to travel, and because they wanted to have a normal life. Because the children could not go to school unless they were vaccinated. They had to be homeschooled if they were not vaccinated. And of course, if they were not at school, the parents could not go to work. So the main motivation was an economic and kind of practical reason rather than a health reason. So it's something to think about when you sort of trying to convince people or trying to promote vaccination campaigns, that the reasons that seem obvious as a health professional may not be the drivers to vaccination in the population. Despite high vaccine coverage at the national level, there were quite a few differences according to communities, and this is a study that I did with colleagues at the Ministry of Health. The vaccine coverage was highest in the non-ultra-Orthodox Jewish population, lower in the Arab population, and even lower in the ultra-Orthodox population. And the most interesting population in terms of vaccine behavior in this study is the Arab population, and I'll come back to it in a minute, because it's, for routine vaccines, the most highly vaccinated population, and yet for COVID, it's not. So we looked a little bit into the reasons why that might be, but I want to talk a little bit about barriers to vaccination in these different communities. In the ultra-Orthodox community, there was a lot of anti-vaccination sentiments that prevented people, that sort of limited the uptake of the vaccine. And this is an interesting population, because it's a population that, by and large, does not use the internet. So the means of communications are different. And if you go to ultra-Orthodox cities, you will see posters everywhere. And this is one poster that I took in a picture, which says, the COVID is a lie, and protect your soul and get vaccinated. And what we realized is that there were anti-vaccination, non-Jewish anti-vaccination groups from the United States that were funding these anti-vaccination campaigns in Israel. And one of the reasons, we think, is because this is a group that really heavily emphasizes religious education at the expense of secular education. So the level of health literacy and basic knowledge of science is extremely low. So it's a very easy target for anti-vaccination groups. And they went all in. And there were, beyond posters, there were entire conferences, especially catering to this population, that was pushing anti-vaccination views. And this is not specific to the ultra-Orthodox community. But there was a deliberate and very organized effort, not only to promote anti-vaccination views, but to even prevent people who wanted to be vaccinated from being vaccinated. And there was this wave, it didn't last very long because the government cracked down on it, who would, in a concerted way, book all the vaccination slots in all the clinics in the country, and then not turn up. They were like fake appointments to stop people from getting a slot from being vaccinated. This was investigated, and the perpetrators were imprisoned, in fact. But a very, you know, a pretty pernicious way to push the anti-vax, not only convince people, but even stopping people physically from getting vaccinated. And one of the last things I want to discuss is the Arab population in Israel. The Arab population is about 20% of the country, and it's generally a discriminated group and an underprivileged group in many ways, socioeconomically especially. But one of the ways that they stand out is in terms of vaccination. The vaccine coverage in Arab children is higher than any other group in the country. And we actually did a qualitative study with colleagues on understanding what are the drivers to vaccination in this group. And one of the drivers, there are several drivers. One of them is very high levels of trust in the healthcare system, despite very low levels of trust in the government. But one of the messages is that vaccination is the normal thing to do. It's a well-established thing, and this is a quote from a mother, and this is not related to COVID, this is related to MMR vaccine. And she said, it's safe, everyone gets it, my mother got it, my grandmother got it, and it's a good thing. But COVID vaccines were seen differently because they were a new vaccine, and there was this very clear distinction between established vaccines and new vaccines. And although they were willing to be vaccinated with routine vaccines, almost without questioning it, they were not willing to take new vaccines because there was not enough, I would say, history and experience at the community level to be vaccinated. Very quickly, ongoing challenges. Obviously, ongoing circulation with emergence of new variants, and nowadays there's very limited surveillance, limited testing. All the fantastic data that we had and that was publicly available through COVID dashboards was stopped, and the funding stopped, so there's less data available. Long COVID is a concern, and I think this is early results from a study that we're one of my PhD students is doing, looking at the timing of vaccination to prevent long COVID. I think one of our saving graces is, what we show in this study is that the pre-infection doses have a protective effect, but post-infection doses much less so. And because the vaccine drive was so early, a lot of people actually did manage to have 2-3 doses before vaccination, and that limits the impact. Nevertheless, we do see an impact. And another study that another of my students is doing is looking at the economic impact of COVID in the country and the inequalities that this introduces. And what we see is that when we look at the economic impact between the Arab and the Jewish population, we see that the Arab populations, who are generally in, I would say, more or less stable employment, suffer much less and were much more likely to lose their jobs and lose income as a result of infection than the Jewish population, and that is an ongoing issue. And another concern of mine, specifically as someone who works on routine vaccines, is the impact of COVID on routine vaccination. And this is a study that we're presenting later this week in Stockholm in the European Infectious Disease Epidemiology Conference, is looking at parents who had a child before the pandemic and a child after, so a paired analysis between these children. And 7% of parents who vaccinated their first child before the pandemic chose not to vaccinate their second child after the pandemic. And about 35% said that the pandemic decreased their trust in vaccines in general and modified their behavior in terms of routine vaccination. So that's a big concern. Okay, so to conclude, and I'm out of time, we started as a leader in COVID in vaccination drives in terms of early vaccines, in terms of booster, in terms of data, and I think there's a lot of valuable lessons, even though our behavior later on and our performance later on was not as impressive. I think there were some factors that enabled that high level of coverage, and I think hopefully some of them are replicable to other countries and are relevant, although some are context-specific. We did encounter some challenges to vaccination, and the drivers to vaccination seem to be different from routine vaccines. We saw anti-vaccination activity to a level that we didn't see with our routine program. The vaccine is perceived differently. It's not perceived as a normal vaccine, and I think pandemic response cannot be treated the same way as improving uptake for routine vaccines. And I think the pandemic, unfortunately, has altered the trust in routine vaccine and will have a long-term impact in terms of population protection, but also in terms of wider societal impact, both in terms of long COVID and both in terms of economic impact. And of course, like everywhere else, there's COVID fatigue. It's becoming more difficult to get funds, to get research funding, and even to get government attention into continuing to investigate COVID. So it's becoming more difficult to have definite answers. And I'll stop here. Thank you.